diverse gender and sexuality and how that interacts with medicine. And when we talk about it from a medical context, and we start talking about emergency medicine and pre-hospital care and paramedicine, there's something called the Dutch model, which I want to talk about. So this is a famous model, and he happens to be trans, and people would probably never know. And the reason for that is because he has had such successful medical affirming care. And that started early on in puberty. And the Dutch model is also called the 12, 16, 18 model. And these numbers are ages, and they're not strict, but essentially it's that we start puberty blockers at the age of 12 to stop someone who is transgender going through a puberty of the undesired sex. Then around the age of 16, after we've given them time to mature and they definitely want this, and this is something that they've thought about, and they don't just wish to socially transition, which means from a social perspective, using the desired pronouns and names and dressing in a certain way, but they also want to medically transition. They can also then choose to add on cross-sex hormones, which will then help them to go through the desired puberty of the desired sex. Then if they want, after they reach the age of legal maturity in the state or jurisdiction where they are, they can then have gender affirming surgery. And so that's top surgery or bottom surgery, and we'll go into that a bit more. But what's sort of important to understand is that if we're able to offer this to people early on, you would never know, because the medical affirming gender care is so successful and so good at helping people achieve a desired result, which is that their body looks and feels the way they want it to because it conforms with their gender identity. And so at age 12, we're looking at puberty blockers. And this is a hitting pause on things. It's completely reversible. It's literally just the pause button. What we're doing essentially is we're working on the hypothalamic, pituitary, and gonadal axis. So GnRH, or which is essentially part of the sort of original growth and gender-based hormones that we sort of talk about. GnRH gets secreted and then starts acting on the glands, which are then going to send other signals down to our sex hormones. So we tend to get GnRH in a sort of constant stream, which pulses. And the GnRH pulses and pulses and pulses as we go through puberty. And as the pulses increase, we start to produce more and more luteinizing hormone and follicle stimulating hormone. That luteinizing hormone and follicle stimulating hormone then goes down and acts on our tertiary sex glands, so our ovaries and our testicles. And it's there that the luteinizing hormone and follicle stimulating hormone then triggers the ovaries and testes to secrete things like estrogen and testosterone. So it's a chain reaction. What we can do, though, is we can totally overwhelm the brain with GnRH, and we can give it a massive dose rather than the pulsed dose. And that massive dose is going to shut down its secretion of luteinizing hormone and follicle stimulating hormone, because it works on a negative feedback loop. So it's going to go, whoa, there's too much, call it quits and give it a break. So instead of being pulsed, it's a consistent amount, and it's higher than the brain's ready to normally accept. And so those GnRH agonists are things like goserelin, leuprolin, leuprolide, triptylin, histrelin. So if you see these medications, that's what they are. And we're using that to overwhelm the axis and to say pause. What's also important is then when we move to cross-sex hormones, so at around the 16 age mark, there's a slight difference here. So hormone replacement therapy is using very similar hormones as medical affirming care. And when we talk about medical affirming care, we're talking about medical care which helps someone affirm the gender that they want to express itself in their body. So there's now more than just these, but traditionally we talk about estradiol or estrogen. and testosterone. And traditionally speaking, testosterone is given by injections, and estrogen can either be taken by a tablet or a gel or a patch.
Okay.
And there's now other options. So we now have got testosterone patches. And essentially, if you can conceive of the body pre-puberty as a blank slate, if I then start hitting it with testosterone, I'm now going to start expressing male characteristics. So the voice will deepen, the testes will enlarge, the bones will change structure, my muscle will change the way it's shaped, my heart will change the way it is shaped. All muscles in the body change in relation to testosterone. The brain changes in relation to testosterone because I'm exposing the body to a hormone, which changes the way it grows. Same with estrogen. If I was assigned male at birth, which is to say, if I have male physical sex characteristics, particularly if I have testicles, I have to also block androgens. And androgens are male hormones. So I need to use anti-androgens. And so for that, I'm going to use spironolactone or cyproterone. Spironolactone is a drug that oftentimes paramedics are increasingly coming into contact with because it's also a very useful diuretic that we use particularly in patients with heart failure or hypertension. So spironolactone is one of the drugs, cyproterone is another one of the drugs, and increasingly we're sort of using newer, not designer drugs, but newer drugs that are coming onto the market. But these are probably the core ones that you're going to see. We use them in different doses to how we would typically use them for diuretics. So someone who was assigned male at birth and has physical male characteristics is going to be on an anti-androgen and also estrogen. Then when we talk about gender expression and medical affirming care, there's also binders. And what binders do is they're essentially a very tight-fitting sports bra or a corset almost. They're thick, they're tight, and they flatten the breasts against the chest to give someone a more masculine appearance. And this is something that all paramedics actually really should know about because binder use is exceptionally useful for people with breasts to masculinize their appearance, which makes them feel a lot more comfortable during the day. But the downside is you have a very tight force constricting the chest. And you can just imagine why that's going to be a problem. So if it's a hot day, you're trying to take deep breaths, you've maybe been a bit puffed by walking or running somewhere, you're increasing the intrathoracic pressure, you're decreasing the ability to take large breaths, you're reducing preload and venous return to the chest, you're more likely to have presyncopal symptoms or a syncope. So it's not inconceivable and does happen every now and again that you will be called to a patient who is wearing a binder. And it's important that you're able to recognize that it is a binder. And also then recognize, well, hang on a second, I've got a situation where I probably need to ask this patient to take their binder off. That's not going to be fun for them. And by that, I mean, it's going to be stressful from a privacy perspective, problem. From a gender dysphoria perspective, this person relies on their binder to make them not constantly feel like they are female during the day by having breasts, and they don't like when people look at their breasts. They don't like, even some people don't like talking about them as breasts because it's really stressful. This is not something that they want. They are trying to masculinize their appearance. And so some sensitivity, privacy, and dignity in this is really important. And like all things, it's a conversation. We don't force patients to do things. If a patient refuses something and they have consent, they have capacity, fine, move on. You want to keep your binder on? By all means. Can we take it off to assess you and to just see how you're feeling because you've had a full syncope? And it's probably not useful to keep this binder on while you're recovering. Be sensitive, be a clinician.
I think the only thing that I would be concerned about is that if there was an issue and I needed to do an ECG, I think that would be
Totally.
A problem, and you would need to take it off. There would be no way that you could do a 12-lead ECG without taking the binder off, and that
totally
you'd need sensitive. Can you kind of talk us through and give us some tips on how you would do that?
Yeah. So I'd basically say, look, I need to do a 12 lead ECG. In order to do that, we'd need to take your binder off. Would you be able to do that, please? And it's important to not just say we need to do this, but to explain why you're doing it. So we need to do a 12 lead ECG because you've had a faint. And why are we doing a 12 lead ECG in someone who's had a syncope? Well, we're doing it to make sure that we don't have an arrhythmia causing that syncope. It's not an arrhythmogenic, cardiogenic cause of syncope. So I need to do an ECG to have a look at your heart rhythm to make sure that your heart's not in a funny electrical rhythm, which could cause it not to beat properly, which would mean that you fainted. It's really important to your health, and it's part of the standard of care that every patient who faints gets an ECG. So I think it'd be really important that we do this. I will try and give you as much privacy as possible. So for this, going to the ambulance, closing the doors, allowing that person to change with privacy. You only need one person in the back at the time with them. You can look away, give them privacy. If they're particularly sensitive and upset, you might, instead of saying breasts, say, can you take your binder off? Because we need to. And some people within the trans community would ask that instead of the word breast, you use the word top parts. I generally just use the word chest. I need access to your chest so I can put an ECG on. We don't need to talk about their breasts, frankly. We're putting an ECG on. We're putting an ECG on. When we go to put an ECG on, something I really don't like that we often do is we use the back of our hands to move someone's breasts to put ECG dots on. It's fine if they're unconscious in an emergency, but if someone's sitting there, they're fully conscious, they're talking to you. I wouldn't lift up someone's arm to put a BP cuff on. I would ask them for their arm, and I'd put a BP cuff on them. In the same way, it's much nicer to ask someone to lift their breast up so I can put an ECG dot underneath their breast.
Mm.
And that's not something specific to trans patients. That's for all patients.
Yeah.
Yeah. So asking someone, can you please lift your breast up? Or if you're thinking this is someone who's in a particularly psychologically vulnerable space, can you please lift your part of your chest up so that I can put the ECG dots underneath? It is
Yeah.
a key thing to
I
give
would
that person
prefer lifting
agency.
my own breast. I would prefer lifting my own breast up than someone lifting my breast up for me. That's
Most
been
women do. The
well.
sonography literature around echo and chest ultrasound does suggest that the vast majority of women would much rather lift their own breast up than have someone move their breast for
Yeah.
them. Yeah.
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 Yeah. And what I
So
normally do is I'll talk myself, like I'll talk through it as well, and I'll
mm,
indicate on myself where the dot has to go. So I need to put a dot here and I need to put a
yeah.
dot here. Yeah. Would you mind um like lifting your chest or just exposing that part of your chest for me?
Yeah,
Something like
perfect.
that would work well
Yeah.
in
Yeah,
that
that's awesome.
situation.
Yeah.
So yeah, we can work through it.
Totally. It's this is not a big challenge for us. This is easy. I've talked about it so that people are aware of it, and just file it in the back of your mind. It's another tool that you have, another piece of the puzzle. Then we get to
Yeah.
18 and we talk about things like gender affirming surgery. So what's important to understand is that people can pick and choose and mix and match what medical affirming care they receive. So some trans people don't want any medical affirming care and they're happy to socially transition. Um, some people want gender affirming medical therapy and also surgery. And so we have sexual reassignment surgery, is what it used to be called. We now call it gender affirming surgery. And
Mm.
so generally we break this up into top surgery and bottom surgery. And this is surgery which helps to either masculinize or feminize the body in order to reproduce the appearance of the desired physical sex. So it might be the removal of breasts. It might be the augmentation and creation of breasts. Top surgery, as it's conceived, tends to be the removal of breasts, and it's becoming more and more common. You'll notice that there is a small scar over there. And like all scars, it disappears over time. There's also bottom surgery, and bottom surgery is either phalloplasty or vaginoplasty. It's far less common. There are very few specialists around the world who are able to do it. Certainly, there's very few specialists in Australia who are plastic and urologic surgeons who are experienced, trained, and offer that surgery. So I'd say there's probably less than 2 or 3 in Australia. And what that means is a lot of people having bottom surgery are going to be traveling overseas. It's very expensive. So oftentimes some people will travel to Asian countries where it is cheaper to have these surgeries. And what that means is sometimes they are lost to follow-up, things go wrong, and they can be back in Australia and they might develop emergency medical complications of surgery, like wound infections, sepsis, fistulas, leaks, and we can be the ones responding to these patients in an emergency. So it's important to understand that this is a surgery which occurs, and have a bit of an idea about what's going on here. It's not too different to any other surgical complication. The risks are always infection, bleeding, clots, and fistulas, which cause connections between places that they aren't supposed to go. So if your bloodstream and your urine are now meeting in the same place, that's a problem. So we've got top and bottom surgery. We've got a few words like chest, genitals, parts, T. So testosterone is often called T. So if someone's on T, how long have you been on T? I've been on T for 2 years. That person's been augmenting, their body with testosterone for 2 years. There's also the words cis and trans. So in chemistry, we know that cis just means one way and trans means the other way. It's just referring to the position of chemicals. And also trans means to move from one thing to the other. So we have the transatlantic. You're moving across the Atlantic. And so when we talk about transgender, it's essentially moving from one gender to another gender. You are transitioning. And so when people are in the process of transitioning, they are in the process of moving from they have a gender identity. They're moving from one outward expression of gender to another outward expression of gender by adapting some of their physical sex characteristics often. So someone on T for a few months is transitioning. Someone on estrogen is transitioning. Someone who's about to undergo top surgery is in the process of transitioning. And so we will often see terms like FTM or MTF, female to male or male to female. And this is a female to male. So someone who was born with female sex characteristics who is now masculinizing their body so that it fits their male gender identity. And along with that, we have sex assigned at birth, which is to say that our society and doctors take a child from the womb and go, this is a boy, and we write boy on the birth certificate, or this is a girl, and we write girl on the birth certificate. And usually that's the case. But we know, based on our previous discussion, that just because someone has what looks like a penis on the outside doesn't necessarily mean that they are a boy. And so sex assigned at birth is this person was assigned that sex at birth. It doesn't mean that that is who they are. It doesn't mean that that's all their physical sex characteristics, and it certainly doesn't mean that that's their gender identity. So I was assigned male at birth. But if I'm a trans woman, one would say I'm a trans woman, but I was assigned male at birth. And so that's to sort of explain that. And a trans woman, so if someone's a trans woman, it means that they had transitioned from male to being a woman. Someone's a trans man, they had transitioned from being a woman to being a man. So that's some of the language. Now it's probably time to talk about sort of the nitty-gritty, which everyone loves to talk about. What increased risks as a paramedic do I have to be specifically aware of? So there's a few things. Every time we take hormones, we increase our cardiovascular risk. And we know that. We know that there is a very high risk for any person taking the oral contraceptive pill and smoking. It is a complete contraindication to be on the pill and to smoke. There is a high risk of venous thromboembolism. That means DVTs, PEs, central venous strokes, so venous embolism strokes.
So the question there is the big risk smoking.
Yes. The smoking in combination with it
Yeah,
massively
yeah.
increases it.
So it's like
It's a combination thing. Even
um,
just being on the OCP itself is a risk.
yeah, yeah.
So
So they
as
both
opposed
make
to,
each other worse.
yeah, they
Um,
synergistically act together to increase the
yeah,
risk of
yeah.
clotting.
So
Uh,
if you want to be on hormones, then you most definitely cannot smoke.
Depends on the hormones. So
Okay.
the combined oral contraceptive pill, um, you cannot be smoking. So there are other contraceptives which are perfectly fine to be on.
Mhm.
But we need to be speaking to our GP about that. So if you are a
Sorry, I just
paramedic,
thought I'd throw that one in there.
yeah, yeah.
Telling
So if you're a
everyone not to smoke.
paramedic, yeah, if you're a paramedic responding to a patient, and this doesn't have to be an LGBTQIA patient, this can be
Mhm.
any patient who is on the pill, and you ask them, do you drink? Do you smoke? And they say, I smoke. You really need to be chatting to them and going, hey, this is actually really dangerous. You need to talk
Mm.
to your GP because it is dangerous to be smoking and being on the pill at the same time,
Mm.
particularly under the age of 30. We know that it is not a good idea. And over the age of 30, as you get older, you have an increased risk of clotting. It's also not a good idea.
Mm.
So if someone is using contraception, an oral contraceptive pill as their primary form of contraception and smoking, we need to chat to them and flag that because oftentimes people have no idea. The other thing is people who are in minority groups with high rates of stress tend to smoke more, the same way that they tend to do more drugs and use more alcohol, because it's a way of self-medicating and coping with distress and emotional dysregulation, which comes from intense fear, stress, anxiety. So it's not surprising to learn that people in the LGBTQIA community have higher rates of smoking than the national average. Um, that unfortunately means that they have higher risks of cardiovascular disease, which puts them at a higher risk of MI, CVA, a whole bunch of other things, hypertension, um, DVT. Obviously, you have to ask your patient if they don't smoke, this doesn't apply to them, but just be aware that this is a population-based thing. More specifically, when we come back to hormones, we know that the estrogen-based hormones tend to have a higher risk of venous clotting, and the testosterone-based, and I'm making a generalization here, the testosterone-based hormones tend to have a high risk of arterial clotting. And so what that means is if someone is taking testosterone, they probably, in some cases, depending on the dose, depending on the person, have a much higher risk of MIs and stroke, particularly thromboembolic stroke. And so that is something to be aware of. You know, if someone is transitioning and they're on testosterone and they're complaining of chest pain, and it's not sounding like typical chest pain, it's like, oh, it's like a weird chest pain. It's probably not please do an ECG. You know, anyone with any form of chest discomfort should be getting an ECG. We know that without troponin, it's impossible to rule out, but be sensitive